Good morning, everybody. Hi. Our topic of today will be discharging a resident to wherever home is. So for that, we're going to start with Deborah Settles. She's our social worker for healthcare. And then I'll take over that. And then also, of course, John will go next. Okay, thank you.
Good morning, everyone. I am Deborah, the social worker in healthcare, and I wanted to start off by giving you some basic information about what I do and what I do in healthcare and what that means as far as discharging you when you are done with your skilled services and therapy. Discharging in healthcare starts pretty much the first or second day that you arrive there. I won't probably talk to you that day of your arrival, just because nursing has so many things and so many assessments that they have to do with you and paperwork that needs to be taken care of. I will probably see you the next day, and during that conversation, we'll start the process of what the discharge looks like for you. And that could be coming back to your home and independent living. Sometimes that is a move into a higher level of care. And we'll start the process at that point about what needs to be done. If you are an independent resident and you're coming back to your cottage or your apartment, we'll discuss, I want you to know that we collaborate and we just have discussions with Lucy and with resident services so that we learn if there are any dynamics about that discharge that could be problematic with you coming back. And so we work with Lucy and resident services to figure out those things and what needs to happen in your process of your stay in healthcare. After we have our initial conversation, I will take that information back to the team and let them know that it is your wish to go back to your independent living cottage or your apartment, or that you recognize that you may be needing a higher level of care, so we're looking at possibly moving into assisted living. Whatever the plan is, we're going to start processing at that time. And we have morning meetings every morning. The IDT team meets in the morning, and we get clinical information from our nurses daily about your stay, about your progress, any problems that they see, whether you've had a fall, any issues that may come up overnight that we need to address the next day. We do that daily, and then once a week, the IDT team meets with therapy, and we meet with John and all of his therapists, and we discuss every single patient in detail about how therapy is going, progress that's made, any problems that they can foresee, and we discuss what the potential discharge plan is at that time with the whole team so that we can all be working towards the same goal of getting you back to where you want to be. And in those processes, we learn a lot of information from therapy, the therapists themselves that actually work with the residents, which is really good information because they're telling us, day to day what is happening, what restrictions, what limitations you might have, things like that. So in learning all of these things, we will have an initial care plan with you when you arrive at the facility. Within the first 3 to 5 days, we will meet with you. We will meet with your family members, your powers of attorney, so that we can all be on the same sheet. We can answer questions about what the stay looks like. John is pretty good about, everybody wants to know when they get into healthcare how long they have to be there. That's the first question that comes up. How long am I going to be here? And typically we don't know that. It honestly takes a week or two till we figure out where you're at in the process and what needs to be worked on and how much time. Once we start talking to the therapist, we get a better sense of what that looks like. So the initial care plan that we have with you is more informational about the processes that we do. And then the second care plan that we have with you can give you more information about how long your stay might be and what problems you may have identified from the therapist and things like that. If you are an independent resident and you are moving into a higher level of care, assisted living, I will reach out to Rachel and Stephen and talk with them. We'll find out about availability of units. And when the process is done, they will come and they will do an assessment on you to make sure that you qualify for assisted living. And all of those processes will be explained to you during the process, when it's happening, what their requirements are. And then when they finally come and talk with you, we'll have another care plan explaining what they found out, what needs to be done, and things like that. If we don't feel like it's appropriate, we'll let you know at that time as well. We answer a lot of questions during the process, and we are more than willing to talk to family members, anyone that is involved in your care and needs to know what's happening with the process as we're moving along. When you're ready for a discharge, I will be the person that will make all of the arrangements. You have two options when you're going back home. You can either have home health, and that's a company that will come into your home. They have a nurse that comes a couple of times a week, and they have therapy that comes same 2 to 3 times a week, depending on their assessment that they do when you get home. And I will set up that referral. And most times, independent residents prefer to do outpatient therapy in the gym that's upstairs. And then if you need any equipment, during our therapy meetings and discussions with John, the therapists let me know what they recommend, whether it's a walker, whether it's a wheelchair. If you need a hospital bed, you have to have a specific diagnosis for that. But oxygen, all of those things, I'm in charge of ordering those at the time of discharge. And I can't order anything until we have a discharge date and we're set for you to be leaving, which makes things really crazy because right now there's a shortage of hospital beds for whatever reason, and it takes weeks to get hospital beds. So we have to work on how do we figure that out. If you're going to assisted living, most of the time we get a bed from healthcare and take it over there and get what you need so that you can get home and start the transfer over. In the process, I have to notify Medicare that your stay is ending. So I will have you sign what we call a NOMNIC. It's a notice of medical non-coverage. And technically we are required to give you at least a 3-day notice, but we try to give you more notice than that. As soon as we're working on your discharge and as soon as John's team lets us know that you're getting close to discharge, we start having these conversations so that you have as much time to plan as possible. At the end, I will help set up transportation with Flo to get you back to either the cottage or Lakeside, wherever you need to go. I will also work with John in setting up companion services if that's something that we decide during a care plan that you might need to help transition back into the home. John is at those meetings and we can set up companion services. And just a reminder, just letting you know, the healthcare team meets daily about your care and all of the information, and we have a thread that we run, secure thread that we run. We are talking to each other 24/7, 7 days a week. Any changes, any falls, any updates, any admissions, any discharges, all of the things that happen in healthcare, the 10 of us, 12 of us are communicating 24/7 about that, so that when we come in the next day, we are all aware of what's happening. So we're really good about communicating, really good about sharing information. And one of the things that's part of the process for the discharge is for therapy to set up a home assessment. John will explain more into detail about that, but we prefer to do a home assessment with independent living residents just so that we can identify any possible complications that are in the home that we aren't aware of. John's team will come in and do that assessment, and then we can work those things out too before you get home. Sometimes it's putting bars in the restroom. Sometimes, whatever recommendations they have, we work towards getting all of those things done before you leave. Does anybody have any questions?
I have a question.
Yes.
What does home health services consist of? Okay. What does home health care services cover?
When you are a patient in healthcare and Medicare is paying for your stay, home health is part of that discharge process. Medicare pays for that as well, and it includes a nurse that comes to your home 2 to 3 times a week, and it includes therapy, OT, occupational therapy and physical therapy, and sometimes speech therapy if it's recommended that you get that at home. What happens is, say for an example, you leave on a Wednesday. So you'll get home Wednesday evening. They will usually come out, whatever company we decide that we go with, they will come out the next day on Thursday. They will do an assessment with you in your home. And it's at that point they decide how long the therapy runs and what is going to be done within your home. You have the ability to approve that, to decline it. You ask as many questions as you want, but they set up the length of therapy during that assessment. And then let's say, because home health is temporary, it could be 2 weeks, 4 weeks, 6 weeks, depending on what they find during that assessment. And then they decide that you need additional home therapy, you need more time. We can get an additional order to extend it if we need to do that after the fact.
How long do I have to wait to get the home health to be in my house?
How long do you have to wait?
Yes, for them to come over and do the evaluation.
It's usually the next day after you discharge.
The question was that how long do I have to wait for the home health to go to my house and do the evaluation? So that's
I do the referral as soon as we set the discharge date for you, and I'm talking to the rep from the company, and they're aware of the day that you're discharging. And because of the way Medicare bills, the services can't pick up on the same day. So you have to discharge on day 1, and they come out on day 2, for example, that it can't be on the same day. So it's usually the next day that you get home. And then they'll do the assessment and start setting up the services after that.
okay. Thank you. And my name is Enrique de Luna. I'm the Assistant Director of Nurses for Healthcare, for those who don't know me. Now, once the floor nurse knows about the discharge information that we have, that you're going home or you're going to your apartment or assisted living, then the nurse will do a discharge form. That's a recapitulation of your stay. It will be a step, every discipline, it will include any discipline discharge instructions for you to take home or to follow at home. That also includes the medication list and how you are going to take it, how the doctor wants you to take it. And you will also have some of the medication that you'll have already there. It is important to note that you will contact your physician within 7 days of your discharging, and that instruction will be given to as well for you. It'll be there. There is a problem sometimes when people want more medications, because we can order that, but if you have BAMC or other pharmacy that you get your medication from, and you try to do it, and sometimes it'll be too soon, so you'll probably be off cycle of your medication as you go there to another pharmacy. So we would probably want to encourage you to go call your pharmacy as soon as you get home, so that way, if you don't have you have enough time to get your medication and go back on cycle. Once again, it's because if we order more than we should, you know that it's going to be off cycle, and then you'll be like too early to refill, and then you're going to be off with certain medications. So that's want to make sure that we get that on time. You don't be without your medications that you need to be at. Okay. Do you have any questions about that, about the discharge? So the floor nurse will go over as soon as they know that you are discharging. The form is filled out. Every discipline is going to put instructions on what needs to be done. And then the nurse will go over to you and explain that either to you or to your loved one, what needs to be done when you get home. Okay? Questions? Yes? Just bring in the, he's bringing.
I presume that every patient's discharge criteria is unique to them. Can you talk a little bit about discharge criteria, and how do you know that a resident is ready to go back home? How is that determined? What are some of the kind of sort of qualifications or criteria to go back home?
Okay, thank you. Yes, this is one I will let it to John, because it is mostly referred to how if the resident is ready to go.
Let me come back to that towards the end. Deborah kind of stole a lot of what I was going to say, so, you know. But I wanted to start off by dispelling a few rumors about discharge. We are not trying to suck you down to healthcare and keep you there forever and ever and ever. We're very busy, we're very full, we have plenty of work, okay? Contrary to some other places that you could go, they're real close, we discharge you based upon when you're ready to go and when you've reached your functional mobility highest level or back to where you were at. And that is different for everybody. One of the 10 commandments of therapy is thou shalt not covet others' progress as thine own. Okay. Everyone is different. Everyone has different medical history. I mean, there's just so many variables. Everyone is different, and that's how we're looking at it. Some of these other places, they're really, you're there, and it's just a time. Time's up. Go home. And they will send you home, whether you're ready or not. And it's unfortunate because what happens is sometimes they go home and they're not ready to be home. And then that's usually when we're getting a call at the last minute. Oh my goodness, can you find a room? You know, and that's unfortunate. That's not fair to the resident. But anyway, the other rumor that I wanted to dispel is in order to be discharged, it is not true that you have to wash my truck. Okay? It's not true. I only did that once. Hey, and I got a call from HR or somebody, some state authority. But no, I'm joking. Discharge starts, as Deborah said, really, it starts, honestly, it kind of starts even before you get there, while you're still in the hospital. Because like you said, we're having meetings, we're talking what's going on. But it definitely starts the day you get there, especially from a therapy standpoint. When you get there, you're going to be asked a lot of questions, and you're going to be asked a lot of questions that are the same questions. You know, but we want to, you know, I mean, we want to know, A, when I come in, we're asking you questions, what was your previous level of function? How are you getting around? Where do you live? Who do you live with? Did you use a walker? Did you use a cane? Did you use nothing? Were you driving? You know, are you in independent living? Are you in a cottage? Do you have a spouse? Do you live alone? All these questions kind of paint a picture, okay? And it helps us get a better picture of when and where you're going to be discharged. Now, obviously, through this whole time, you were in control. You know, I mean, you have the right to, you are not a prisoner down there. You have the right to leave at any point in time. Now, we may recommend you don't leave because you're not ready, but you do have that right. I want to point that out. Isn't that right, Deborah? She's real big on that. But anyway, so we get all that information. My goal is always to get you back to the previous level of function. Where were you before? If you were in independent living, that's where I want you to go. If you were independent before, that's where I want you to get. If you were in assisted living, then that's where our plan is. And that seems master of the obvious, but you know, that's always the goal. Do we always get there? No, we don't. We don't. So as we go through therapy, and you were asking, you know, when do we know somebody's ready? It's an educated guess sometimes. But generally speaking, if you are able to do all the things that you normally do in independent living or assisted living or wherever you were at, and that could include, you know, can you tie your shoe? Can you put your shoes on? Can you put your socks on? Can you put your pants on? Can you toilet yourself? How far can you walk? Are you safe? What is your balance? Can you do the things that you need to do? And here's one of the key words: safely. Now, if you weren't safe before, that may be a goal that is, we may not get you better than you were before. But again, we want to get you back to wherever you were before. But if you're able to do it downstairs in healthcare, in theory, you should be able to do it upstairs. Now, sometimes that is not true. Some people need that extra cueing, that extra help. They may not be able, just because you can do it down there, structure was the word I was actually looking for. You may not be able to do it. But that's the first thing we're looking for. Can you do it down here? If you can't put your socks on down here with help, you're not going to be able to do it upstairs magically. If you can't toilet yourself, People have this idea that, oh, once I get upstairs, I'll be fine. Well, no. If you can't do it downstairs, you're not going to be able to do it. But as we're watching, as we progress, we have markers that we watch, different levels that we do. And as you start getting closer, we start talking more about discharge. At some point, we're going to want to do a home assessment. We do not have to do a home assessment. Some people don't want us doing it for whatever reason. We like to do a home assessment. You know, we just did a home assessment 2 months ago, we probably don't need to do a new one. And the good news is most of the places here are perfectly fine. But we go in and what do? We do the same activities of daily living that you've been doing in therapy. Can you get in and out of your bed? Is your bed real high? Do you got to kind of jump to get into the bed? Are you in danger of sliding off the bed because it's so high? Can you get in and out of your shower or your bathtub or shower tub or whatever it is you have? Do we need to put in bars? Do we need to get a shower bench? It's very specific to your situation. Okay, and then when we're there, we're going to say, well, where do you sit during the day? Okay, well, go sit where you sit, Turn the TV on. Let's see how you do. What? Oh, you go to the computer? Okay. Go sit in that rolly chair. Ooh. Not a fan of rolly chairs. But there are some things you can do to make it safe, and that's what we go over with you. Make it safe. It's all about safety. And finally, during the home assessment, I will point out things that I don't like, or the therapist will point out things that they don't like. Now, we are not here to redecorate your place of living, and we are not fashion designers. However, we really don't like carpets, throw carpets, rugs. And again, I'm not going to go in and tell you, you've got to get rid of this rug. No, I'm not going to do that, but I'm going to point out, hey, this is a really dangerous area, especially the ones with the little tassels that they flip up. This is a real concern here. Hey guys, man, you've got all this stuff here. This is a really narrow pathway. Let's move some of this furniture out. Some people have stuff like really cluttered, and I'm like, well, guys, we need to clean this area out. Guys, this area right here, this is a real concern for a fall, so that you're aware of it. I cannot tell you how many times I've done a home assessment and have gone up there and said, hey, I'm really concerned about this area. And then a month later, 6 weeks later, they're down in healthcare. Why? Because they fell. And then they look at me and go, I fell. Right where you said I was going to. It's not because I'm brilliant, it's because we've been doing this a while, and you know, but so those are the type of things that we're doing at the home assessment, okay? Trying to make sure it's all about safety, quality of life, and functional independence. All of it is. So once we get that done, we come back, then we need bars, or maybe we need this, then we're going to place an order with maintenance, get the ball rolling on that, depending on how long it takes to get that done. And then before you even leave, we'll have the discharge orders, depending. We will have a discharge meeting, we'll plan on what we're going to do. Are you going to get home health? Are you going to get outpatient? You don't have to get either one, but we recommend it. And that is certainly your choice and whatever is best for you. And then at that point, let's say you're going to do outpatient, we'll have the order. You go home. We usually like to give you a couple days at home before we call you to kind of get settled in, and then Ramil or Jeff or somebody will call you about setting up an eval for outpatient, and then you would continue on outpatient 2 or 3 times a week depending on what they feel is necessary, just as follow-up. Well, like I said, it's an ongoing process. Everything is geared toward getting you back to that previous level of function. Now, back to your question, kind of, I know I've sort of answered it. You know, are there people who go home and did not get back to their previous functional answer? Absolutely. Absolutely. You know, maybe there's modifications we need to make that can get you back to that level. Maybe you just need a little bit of help. You know, and that's where maybe home health can continue, or caregiving, or whatever. Again, you're not a prisoner down there in healthcare. So ultimately, where you're discharged is a decision that's going to be made by you and your family with our input. And it is an ongoing thing from the day of admission all the way through. And by the way, once you go home, you're still our patients, all of you, everybody here. And our door's always open. Okay? Any questions about any of that? I was gonna say, I gotta have at least one question.
If there is a disagreement, how does that handle? In other words, you say, I gotta have a wheelchair to go home, and I disagree. What happens?
Well, I'm right.
But.
No, I'm joking. That's a joke.
But I think you said we were not prisoners.
Yeah,
So-
exactly. My job is to educate you, convince you, but you have the right to do whatever you want. If you say, John, you're an idiot, I'm not getting a wheelchair, that's your right. So I guess in that instance, I may be right, but I still lose the war. And you do what you want to do.
Thank you.
John, I just want to get a distinction again. You said when we discharge and we go home, Medicare pays for, is that what you call home health?
Yes. Medicare will pay for home health for a certain amount of time. It does not go on forever. And it could be, 2 weeks, 10 days? It could be 4 weeks. It all depends on what your need is and what they decide, the home health decide. Based upon that initial assessment and ongoing assessments. I mean, they're going to do ongoing assessments like we do, and they may say, okay, no, we think you need another 2 weeks or whatever. In relation specifically to therapy, just FYI, it is not unusual that you may get home health and then continue with outpatient. Especially if you're having, say, a knee surgery. You know, these knee surgeries, they want them, they really, like Ursulane really wants everybody going home. They go home, they get home health for 2 weeks, boom, they're up in outpatient. It's automatic. That's what he wants. So that's, I don't know if that
So does
answered
the
your
average
question.
person, like again, for like knee surgery, go from the hospital to the healthcare? Or hip surgery? Do we know?
Hip surgery, they're generally coming in. There's so many factors. It depends on what was their previous level of function. But ultimately, it depends on, they've had the surgery. Are they medically stable? Are they not medically stable? Can they get in and out of bed? Can they function at home reasonably and safely? That decision is generally made at the hospital level. And of course, we're usually aware of what's going on. And we have people who have gone home after surgery, got up there, and realized, I can't do this. And then they call us, and then we're scrambling to get them down there, which we don't like doing. We'd rather have it planned out. Mm-hmm. But others go home just fine.
Is there ever a case, though, when, if I get knee surgery and you can't get me into the healthcare, that healthcare is booked?
I am not aware that has ever happened in my 25 years where we didn't take somebody. Debbie, you can correct me if I'm wrong, but in my 25 years here, I've never seen that happen.
It might be a little bit of a delay of that, but we're making.
Yeah, there may be, thank you, Enrique, that's a great point. There might end up being maybe a delay where we're moving people around to get set up, and then, because it's not just we'll move this person over here, and then, no, the room's got to be cleaned, disinfected, there's a whole process to it, so it's not necessarily automatic the same day, but like I said, I've never heard of anybody not getting admitted since I've been here.
And one last question.
Yeah.
You talked about home health care, and then the other is what we called it home companion, or if we.
Right.
Does Medicare pay any of that?
Medicare will pay for home health skilled therapy. Companion care is not skilled. It's just somebody who comes in and helps you with activities of daily living, such as getting dressed, bathing, maybe doing laundry, going and getting your mail, making you light meals, any activity of daily living. But that's not considered skilled, and Medicare does not pay for that. It's private pay, yeah. Any other questions? Uh-oh, now I got a hard question.
In trouble. No, a couple things I wanted to mention. They talk about not being a prisoner in healthcare, and the reason they talk about that is really for your benefit. Medicare will not pay for you to be in skilled nursing if you travel and you're going out, you're going back to your cottage. You have to be homebound in order for them to cover that stay. So they're really advocating for you. If you leave healthcare kind of against medical advice, Medicare's not going to pay for that. So that's one challenge. The other one is, if you go against the medical advice, you had a question about you don't want a wheelchair and they're recommending one, typically they'll document that. We recommended Colonel Hebner have this intervention. She declined. Here's the risks she's agreeing to take on because she's not following that advice. So we have to document that and then track it. So that's part of it, how we do that. And lastly, typically in healthcare, we have about 58 residents that are physically there, and we have 91 beds. So there are a lot of capacity, and our challenge is managing the private rooms. Sometimes a resident wants both sides, and they agree to pay a private room. But if you think about that, 58 residents and 91 beds, we have about 32 possible beds that we could care for folks. So we'll continue looking at that and manage it. It's a good problem to have, but I hope that helps clarify a little bit about, discharge against advice and not following recommendations. You have that choice and that right, but they're going to document what we had recommended and that you're not following that advice, so kind of you assume that risk. Does that make sense?
Yeah, and again, like I said, that's kind of our job, is to make sure that we're educating everybody. Okay, this is what I think because of this, and this. But again, I think everybody in healthcare is big on patient rights and being a patient advocate. So, yes.
If you need companion care, I understand you have to pay for that. How do you arrange for it?
Well, you can call me. You can call. What was the question? I'm sorry. The question was, how do you arrange for companion services? You can call me. You can call Kanika upstairs in the outpatient therapy gym. You can call resident services. All of those are ways to get the ball rolling. Any of those three. Or you can even call healthcare and they'll let me know too.
John, just more of a support than a question, and following up on what you said and what Steve said a few minutes ago. As a personal experience, I've worked with students in special needs situations, tried to influence the parents to do the right thing, use the wheelchair, use the walker, don't fall in the hallways, all that. My wife's had many hip surgeries and things, and when she went to therapy here, it was very useful, very helpful. But she's been in situations where, she would fight with me. Don't want to do this, don't want to do that, and then, something happens, like you said, with the table too cluttered and you have a fall and it's right where you said it was going to be. So my advice, and my talking to people in the ARC here, is follow the professional's advice, follow their guidelines. That's always worked for us. When we've tried to do it ourselves differently, it hasn't worked for us. So now my wife's a little bit of a better patient, as you know. Thank you.
Yeah, I do not have any stock in wheelchair companies or rolling walkers or anything like that. I have no vested. I really, honestly, the only thing that I really want is safety, safety, safety. The best fall is the one you can prevent. Using a walker versus using nothing, if you need it, statistically just decreases your risk of falls by a significant amount. Okay.
Earlier, Deborah, you mentioned about the shortage of hospital beds, and I think what you were referring to was physical hospital beds to go into independent living apartments or homes. She was not referring to capacity. capacity in healthcare. I just want everyone to know there's plenty of capacity in healthcare. Like Steve said, but the hospital bed availability, the physical beds in the industry, right, or in San Antonio, may be limited, and that's why advanced warning is needed.
Yes, absolutely, that is correct. I was not speaking about the beds in healthcare. It is when you go home and if a patient has respiratory issues or, needing a bed, a hospital bed in your home when you leave. I can order that for you, but recently it's been taking 4 to 6 weeks to get a hospital bed for whatever, and it's a long time. So depending on where you go here on the community, you're very fortunate because we can usually come up with a bed in healthcare that we can provide for you until the other one is coming, and then we can swap them out, kinds of things. We've done that numerous times at the assisted living level, where we provide the bed until theirs arrives and comes. And one of the other things that I wanted to mention with Medicare, I am able to order either a rolling walker or a wheelchair. I cannot order both. And Medicare will only give you either one of those items every 5 years. So when we are discharging you and when we are making our plan, we always recommend, if you need something, order the wheelchair. It's more expensive. You can privately pay for a walker that's pretty inexpensive depending on where you get it.
Or if you just want a basic one, they have babies in our closet.
We have tons of them, and on occasion, I reach out to the estate sales and things like that. When they have medical equipment, I will go and pick up whatever they will give me for free so that we can have it on hand for whoever needs it when it comes up. I usually do that with Miss Cape and things like that. But yes, I was referring to the hospital beds that I order upon your discharge. And one of the other things that I just wanted to mention real quick was that I wanted everyone to understand that there are a lot of us on the IDT team, therapy, nursing, social services, dietary, all of us together. When we plan a discharge for you, there isn't any one single person that says you're ready to discharge. It's a collaborated effort with all of us. We sit down at the table, we discuss all of the concerns, all of the progress made, and you don't get a discharge from us unless it's completely safe with all of the departments. We make sure that everything is covered. Sometimes residents have dietary issues. Arlie will address those issues. Depending on what the concerns are, it's all of us, and it's a collaborated effort. Not any one person has the ability to say, yes, they're ready to go.
And ultimately, it's the doctor has to, I was just saying, and ultimately the doctor is the one who has to sign off on it. Because we've had people who were totally functionally independent, but medically they weren't stable. Correct. So they were still having to stay down there. But one other thing I wanted to say was, we like to plan our discharges. We don't like sudden discharges. Now, we've had people, no, I'm going home and I'm going home today. I'm going home now. And somehow we always manage to pull it together, but it's not easy and it's not what's best. Oh, yeah. So, we like to take the time, make sure everything that's set, setting things up, setting up home health, making sure you're getting a bed or this or that, whatever it is you need. It all takes time, and it's not instantaneous. So if you're in healthcare, you want to go home, and I want to go home today, we get it. But sometimes we can only make these things move so fast. And on the day of discharge, you will not get any therapy. That's a Medicare thing. So I just thought I'd bring that up. We like to plan our discharges.
A lot of them want to leave, like, after they've done therapy, they're like, I'm ready to go.
Yeah. So, yeah, that's another thing. We'll do therapy. Okay, I'm leaving home today. Well, no. Yeah. You had therapy today, so you got to wait one more day.
One thing I would like to mention is in regard to John and Deborah mentioning that discharging is a very, very planned process. You've probably heard that so many of us don't want you to go home on a Friday. Mm-hmm. And the reason for that is because regular staff is not here on Fridays. As Deborah mentioned, the interdisciplinary team really does look out for each and every one of you, and typically they're not here on a Saturday or Sunday, so if something happens, it's the weekend staff that are here. It's okay, but we would prefer to discharge you Monday through Thursday and make sure that you're ready to go home for that whole weekend without our support. Also, after John finally discharges you as an outpatient resident or patient in therapy, Carrie Mendez has such a robust program in her fitness area, and typically John's team will turn the baton over to Carrie to follow you with either some personalized fitness programs, engage you in one of her sessions that she has programmed during the week, but the success story is ongoing for your recovery. And I just wanted to make mention of that during
absolutely.
the process.
Yeah. I know they work really closely over there, even upon discharge from outpatient over there. So, yeah, and she does a great job up there, so.
What is what is the difference between A wing and B wing?
You want to answer that?
And actually, there shouldn't be any difference because we are actually certified, Medicare certified for the 91 beds that we have. So the care should be the same, and just different people, of course. We'll make sure that all our nurses are capable and competent to provide the care that they need. And that also takes a big role on when we have the information about you when you are coming from the hospital. A through review of your clinicals, or the clinicals that come from the hospital to us to see where you are going to be, where is the best place for you to be. However, there should not be any difference. We do have our residents that are in skilled care, Medicare Part A in both hallways, and also in the Oaks as well. Okay.
Yeah, I was going to say, don't worry, we'll find you for therapy, whatever wing you're on.
Can you talk about some of your outcomes? Amazing.
Yeah, and I didn't bring any of those statistics, so I apologize. And I know I've given a couple presentations on it. But basically, Medicare is constantly, they're just gathering data. And when you come in, we do the evaluation, and they have these measures, quality measures, functional measures, which include eating, lower body dressing, upper body dressing, toileting. Can you put your shoes on? Can you get in and out of bed? How are you getting? Can you sit to stand? Can you transfer? Can you get in a car? Can you go up steps? All these different things, and they have a score. And so when you come in, we have to gather all that data, which we're always doing, for our own. But we send it into Medicare. Well, we've been sending it into Medicare for a while. And when you discharge, we have to come up and re-evaluate those things. Where are they at? Okay? And Medicare, and I don't know the exact formula of how they get this, but based upon age, this, that, or the other, and your score when you come in, Medicare in its wisdom has come up with a score that they expect you to be at when you are discharged. Now, some people unfortunately don't get better, and so we don't meet those goals. But our numbers, and I don't remember exactly what they are, but they are astounding. And if anybody wants it, I'd have to run the report. But we get this score, and our scores are very, very high. And what they do is they take those numbers and they compare it to other people in the city, other people in the state, and then where we are nationally. And Steve, do you remember any of those numbers off the top of your head? They were almost double what the average was in almost the city, the state, and the county. I mean, they were just like, whoa, very high. And the thing that I like about that measurement tool is I'm not the one setting this score, it's Medicare. So I have no control over that. So it's just one of the ways that we kind of we measure our functional outcomes and our quality, and all those outcomes, it's a team effort, and a lot of us down there, we're working hard to get everybody back to where they were before. So, yeah, I think I did that. Debbie, was it maybe 3 months ago, 6 months ago, something like that?
I was super impressed.
It was really amazing. Yeah, it was really. I was like, because we kind of just really started looking at those scores and these reports from Medicare. But even I was kind of, whoa, this is really high compared to the national average and the state average.
So we're just super excited, and I think it's a good testament of John and his team and the kind of services they provide. Outstanding.
Yeah, and my team, most of them have been with me a long, long time, and they make me look good, which is hard to do. So I give them all the credit. I really give them all the credit and give these guys all the credit. So.
And there was a question earlier about B wing and A wing, and previously at the ARC, we only had 8 Medicare beds in the entire healthcare center. So those were only on B wing. Then a little later, we went to 12 certified beds. So all that used to be different. B wing had all the rehab residents, and the rest of it was what we called long-term care. But now we've certified all the beds, and that benefits you because we used to get in these problems of you can't go back to your own room because you have to go to the rehab area, right? So it caused a lot of problems and helps with roommate compatibility and personal preference, and really helps meet your goals. So,
Steve, when I started, I remember we had 2 Medicare A patients here when I started a few years ago.
I've seen it get that low, and then our high is about 33, which is amazing.
Would you explain the difference between assisted living and health care?
Deborah, you want to take that one? Enrique?
Okay, and assisted living is mostly what you require supervision. You require supervision either for your activity or daily livings, like going to supervise dressing up, or supervise going to the bathroom, so you are safe to go in there back and forth, and medication supervision as well. So that's mostly that we have an assisted living. We are able to do those. You are able to transfer from point A to point B with minimal assistance. And with healthcare, actually, if you require more than that, and also a skill service, such as you have more constant being changed in bed, needing to be fed, more medication. Instead of supervising you taking the medication, is giving you the medication. That's mostly, roughly what I can say.
Okay. Yeah, that's a hard question, but you need a higher level of care in healthcare than you do in assisted living.
Just a comment. I was a guest in your place last year for 2 weeks, and I wanted physical therapy after I left healthcare. And the key is to keep your primary doctor informed, because your doctor then can refer you to the
You have to be referred.
right here. Otherwise, you could be sent across town or someplace, but your doctor is the key.
Yeah, we have to have a doctor's order to do any therapy wherever you are, but you have the right to get therapy wherever you want to get it, whether it's here, somewhere else. I mean, you have that right to choose. So. He just said that his doctor had never heard of this place. So well, we're working on that.
The term companion services has been used a couple of times. Could you explain what that is?
It's just basically, I'm going to use the word caregivers is probably a better word than companion services, but basically, it's, let's just say I'll use the example of Mrs. Jones who had a knee replacement, and she just needs a little bit of help with a shower, for example. Just somebody there to help her with a shower and get dressed. So that's not considered a skilled service. She doesn't need to be in healthcare for something like that. She can go home and have somebody come in and just help her with that one thing. Take a shower, help her get dressed, or maybe a few other things, maybe laundry, maybe breakfast, or whatever it is. They can come in, you're in your own home, but it's not skilled, it's private pay. So they just basically help. It's a way for people to stay in independent living as long as possible. So maybe you're not quite ready to go to assisted living or healthcare. If you meet the requirements, you can have somebody come in and just help you out a little bit to keep you in independent living longer. Therapy, companion services, it's all about keeping people at their level of function and where they're at as long as possible, keeping people in independent living as long as possible, keeping them in assisted living as long as possible. So that's kind of what that is. Did I answer your question?
Thank you. If you're in healthcare and you require skilled nursing, why would you need to hire at your own expense other skilled or other caregivers to come in and augment those who work for the ARC to provide the 24/7 coverage?
Yeah, I'll say a few things and then I'll let Enrique jump in too. There are some people that need one-on-one care for a prolonged period of time. And I'll give you an example right off the top of my head is, say somebody who needs somebody with them while they're eating because they're at risk for choking or aspiration, or they can't even feed themselves, but they're a very slow eater. We have people who literally take, an hour and a half to sit there and eat, okay? That's not feasible for an ARC person to sit with one person for an hour or an hour and a half. Sometimes it's just family choice. They want somebody there. Other times, maybe they're at risk of wandering off or something like that. I'll let Enrique kind of answer that also.
Yes, and in addition to that is that if a resident is exhibiting some behaviors that we cannot control and we will respond better to our one-to-one person, it is recommended that we have someone else to help us with that. Or because of safety as well. They want to make sure that they don't hit themselves or they injure themselves for the most part. So that probably, but that's also a recommendation that we'll set up as an IDT. We're gonna go ahead and do it and call the families, make you aware that will be needed.
The majority of them, though, I think, the majority of people that we have that have caregivers in healthcare, it's initiated by the family. I would say probably, 80%, maybe even 90%. And like we do have people that they take an hour to get ready. So anyway, hopefully that sort of answers.
As well as if the residents are feeling alone, depression, they want to talk to someone, and they have this separation anxiety. A lot of them may have that. I mean, it is very prone. We are in a room by yourself. You are in an unfamiliar place. You don't have your loved one with you. So this becomes a problem. That's what I said about behaviors. Yes.
Yes, I have low vision. Now, if I wanted to hire someone to help me, say, order things on my computer or check out Audible books, does Companion Services, can I get someone to do that?
Yes, but I'd have to make sure it was somebody who was computer literate and could do it. That would be we'd have to make sure we had the right person available that could meet your needs And, but then, you know, for something like that, I know they also have the computer club, and maybe there's some other things out there in the community that could help, you know, help. It might be better suited and is free. I'm always looking for free stuff for you guys and for me too, but as long as it's good quality, you know, but, you know. Did you have a question?
I just want to say that for 5 years prior to February last year, my wife was in health care 3 different times. And everything that Deborah and John and Ricky have talked about, they did an outstanding job. They helped the family. They met with us. They talked to us. They kept us informed. And the people that took care of my wife during that 5-year period were all outstanding folks down there in healthcare, and I give them high praise.
Thank you, sir. But he does bring up a good point that I want to, you know, if you have a family member down there in healthcare, and I know I speak for all of us, yes, that's our patient, but if you're this patient's spouse or its family, you're our patient too. You're important too, because it's very stressful on you, you know, when you have a loved one in the hospital or sick or is declining. It's very, very difficult. So it's even bigger than just the patient that we're treating. It's everybody.
One thing I wanted to say was if you've been down to healthcare recently, you may have noticed a little relocation of rooms. The activities room is now therapy, and therapy is now the activities room. We did a little modification with painting and rearranging of furniture. We added some other equipment in John's area. But all in all, I think it was a really good change for the residents that are in healthcare. And right now, as we speak, we're really trying to upgrade some of the aesthetics. Well, while we're on pause for the capital development plan for just a short little stay. And so we're painting A wing and B wing right now. And you'll see a little movement down there with the contractors, but I think you'll be pleased with the outcome. It's just a little bit of an enhancement right now during our pause, and I think it'll be favorable for all the residents down in healthcare. So go down and take a peek when you have a chance.
Yeah, Debbie, the relocation of our therapy gym is so nice. I don't even know what else to say. I mean, we have so much more room. It's so much better for the therapist. It's so much better for all the residents. You know, we were kind of all like little sardines in that other therapy gym. So it's been really, really, really wonderful.
If you haven't been down, it's really a true change. So go down, visit some of the residents in healthcare, and take a peek at these rooms. Alexis, who is absolutely wonderful, she's a recreational therapist, and she provides so many activities that are out of the box and not institutional thinking. Go down and see that area. I think you'll be quite pleased.
And we are, I think I don't know exactly when it's coming, but we are getting, thanks to various donations, thank you. We're going to be getting a new step down in therapy after all these years, so that's a big, I know it may not mean anything to you all, but it means a lot to us.
Yes, we appreciate all of your donations. You all are so very, very generous in that area, and thanks to Anna Sweden for continuing with that wish list in her office. She does an incredible job in keeping all of us up to date with things that residents are requesting and things that are necessary in given areas. And one of those recipients has been in not only the fitness center, but in therapy as well. Anybody else have any other questions?
What happens if you're in assisted living and you become ill? How do you get from assisted living to health care? Do you have to have a hospital stay?
The hospital stay is one way to do it. If you go into the hospital and you're there for 3 nights, then you would qualify to come in as a under Medicare Part A. Now, let's say you had a decline in function. Deborah, you can, I don't know if you want to take this or just correct me if I say something wrong. Let's say you've had a decline and for whatever reason you need to come over, but you did not have a 3-day hospital stay. You can still come over and we can still give you therapy, but it would be under Part B and it would only be 2 or 3 times a week as opposed to 5 or 6 times a week under skilled therapy Medicare A. It would be under Medicare B. And then the big thing is you would have to, you would be paying for the room in healthcare, which means you would be getting doubled. So sometimes it's I don't want to say sometimes it's to your benefit to get that 3-day hospital if you're that bad off. Yeah. Yes, 3 midnights. Thank you. Yes, and you can't be under observation. It has to be 3 midnights. Okay, I think we're done.
Thank you.